So a warm welcome to the colleagues in the room and the colleagues online. I'm Klaus van Presenting from the Division of Family Medicine. And it's thank you also to the audience online and for your patience, just allowing us to get our technical aspects sorted. But with that no further delay, I'm really glad and honored to introduce Tatum Aronson. Is a recent graduate from the UCT Family Medicine program. I've had the pleasure of working with her since 2020 in a number of waves of the COVID pandemic. And it was amazing to witness her as a clinician in action, but also as a team leader. And also the way she was very involved in helping to facilitate with other colleagues the innovative approach to strengthening the care for diabetic patients during the pandemic. And we are grateful also to Dr. Tasneem Rust and Dr. Prof. Joel Dave as the supervisors for this research project. And we look forward to hearing your presentation, which Tatum has also presented recently at our National South African Academies of Family Physicians Conference here in Cape Town. And yeah, I think looking forward to your presentation. Maybe also there will be some time for some questions and answers to really rethink what are the lessons to take forward in this era. We can't say yet that we're post-pandemic, but we're in this phase where we maybe have some breathing space at least to reflect and think about how can we do things more proactively and differently. But over to you. Thank you so much for being here today.
Okay, thank you, Prof. Klaus. 17. No pressure. Okay, so good afternoon, everyone. My name is Tatum, and today I'll be discussing a novel approach towards treating high-risk diabetic patients during a pandemic.
I'm just going to hide that. If you just twist that one at the perfect.
Thank you. Okay, so this is was my IMED research study. It was entitled Early Identification and Elective Inpatient Management of High-Risk People Living with Diabetes Diagnosed with COVID-19, Decreases Morbidity and Mortality. It is a quasi-experimental study. The co-authors were Dr. Tasneem Rust from the Family Medicine Department and Prof. Joel Dave from the Endocrinology Department, both at UCT. So in November 2019, the world was informed of the first cases of coronavirus disease caused by the SARS-CoV-2 virus, which rapidly escalated into a full-blown pandemic in early 2020. And in Italy, it was noted that diabetes mellitus was 3 times more prevalent in patients with severe COVID-19 than in the general population. So it was thus anticipated that diabetes would also predispose to increased severity of COVID-19 in South Africa. So in Cape Town, the first field hospital, which was an 862-bed Hospital of Hope, was erected in the Cape Town International Convention Center. It was set up in May 2020 in response to the COVID-19 pandemic and admitted the first patient on the 8th of June 2020. So the Hospital of Hope offered inpatient intermediate care. The Western Cape Department of Health also established a telemedicine team, which was the Vector team, that fast-tracked at-risk people living with diabetes diagnosed with COVID-19 into the Hospital of Hope. So the traditional approach for admitting patients is to wait for severe illness to develop and then admit. Whereas this approach was to identify high-risk patients and then admit prior to the development of severe illness. So the Vector team is a telemedicine initiative from the Western Cape Department of Health. It stands for Virtual Emergency Care Tactical Operation. It was headed by one of our family physicians also at UCT. It was a group of medical officers that obtained data from the data center, which ran an algorithm to generate a line list of high-risk people living with diabetes with a COVID-19 diagnosis in a 10-day window. And these patients were then allocated to the medical officers who contacted them telephonically, usually on a daily basis, to offer them elective admission to the Hospital of Hope. So this was the CTICC. It was an initiative from the Western Cape Department of Health in response to the COVID-19 pandemic in Cape Town. And this is the building. And this is where an intermediate facility was set up at the Cape Town International Convention Center. So this center is actually usually used for social events and for conferences. And in 2020, it actually became a hospital. And this is what we call the Hospital of Hope. So this is an aerial view of the Hospital of Hope. So as I've mentioned, this was an 862-bed hospital. So what you're seeing here is only a portion of the actual hospital. And we divided up each section sort of into wards. So we had an acute admission ward, we had a high care ward, which had high flow machines, general medical wards, and palliative care sections. So each ward was then led by a team leader. And this ranged from family medicine physicians to family medicine registrars, as well as an emergency medicine physician and one internal medicine physician. So, but we were all quite junior. And so other services that we offered was that we had medical officers who were also junior. Most of them had just qualified from the community service here. We had nursing staff, most of which were also junior. And then we also offered radiology. We had a mobile radiology machine along with one ultrasound machine. And then we had dietitians, we had physiotherapists, we had social workers, and we had a pharmacy team as well. So this is an image of one of the wards at the CTICC. So what the most important thing we had there was beds. And in 2020, that was prime real estate, basically. But what you don't, I don't think you can appreciate it here is the oxygen, which was also very important, attached to each bed. And the piping actually ran just above this prefabricated walls. But at that stage, this was actually life-saving for patients. And so this is an image, obviously, of the President of South Africa and the Western Cape Premier. They visited the facility just prior to its opening. It actually took 26 days to complete, which is quite a feat. And it offered step-down or intermediate care to surrounding hospitals, which included Witwatersrand, Somerset Hospital, Victoria Hospital, and Mitchells Plain District Hospital, amongst others. So back to my study. Diabetes is a global public health problem and is one of the leading causes of morbidity and mortality worldwide. South Africa's healthcare system is not only overwhelmed by escalating prevalence of non-communicable diseases, but carries an additional burden of disease due to TB and the HIV epidemics. So we didn't have a lot of literature at the time, so most of it came from China. And this one was quite a large one. It was a retrospective multi-center study in Hubei province. It investigated 952 patients with pre-existing type 2 diabetes who were also diagnosed with COVID-19. So what they found was that people living with diabetes required more medical interventions and had a significant higher mortality. They recorded 7.8% versus 2.7%, and multiple organ injury than those without diabetes. They also showed that glycemic variability between 3.9 and 10 led to a significant reduction in medical interventions, major organ injuries, and all-cause mortality. And so glycemic variability has been shown to be an important indicator and a possible risk predictor for death and other complications in individuals with type 2 diabetes mellitus. So efforts to ensure good inpatient glycemic control are therefore the cornerstone in the management of people living with diabetes who are diagnosed with COVID-19, especially in the context of field hospitals, where you have a rapid turnover of patients and you have inexperienced staff. The use of clinical protocols assumes increased importance. So diabetes itself can be regarded as a chronic inflammatory condition characterized by multiple metabolic and vascular abnormalities. There's also a dysregulated immune response, increasing the diabetic patient's risk of infections. So this, together with an augmented inflammatory process, may contribute to the underlying mechanism that leads to a higher propensity to infections with worse outcomes. So as we know, there are lots of national guidelines all over the world and standards of care for diabetes, and they're available in many countries. But translation of practice recommendations from developed countries to the practical care of people living with diabetes living in developing countries is challenging, as there is differential access to various aspects of care. So Davies et al. In 2020 showed that COVID-19 and diabetes comorbidity had dramatically higher mortality rates than COVID-19 patients without diabetes. And local data also similarly in 2020 demonstrated that there's an increased mortality in patients diagnosed with COVID-19 who are elderly, they had diabetes mellitus, they had hypertension, and renal impairment. So to summarize all of that, so diabetes leads to an increased morbidity and mortality, leads to an increased risk and severity of infections. It also, we found that it increased the risk for severe COVID-19 infections. And one of the literature texts speaks of the COVID-19 storm, the cytokine storm. And they describe having added diabetes to that storm. It then becomes a super cyclone of events, basically. So it was therefore decided to offer high-risk people living with diabetes an elective admission to the CTICC Hospital of Hope, with the hypothesis that this would prevent increased morbidity and mortality. So high-risk patients aged more than 65 with or without renal impairment diagnosed with COVID-19 who did not fulfill criteria for acute hospital admission at the time of their diagnosis were identified from the provincial data center and offered direct elective admission into the Hospital of Hope via telemedicine service. So that was the Victor team. A consensus document on inpatient diabetes management in the form of inpatient practice guidelines were adapted from a nearby tertiary hospital, so namely Groote Hospital, and implemented at the Hospital of Hope. So that's one of the brief summaries that we used. So these were the guidelines that were actually being used at Groote at the time, which we then implemented at the Hospital of Hope. So that's one of the pages, one of the summaries. So the aim of my study was then to assess the impact of this early elective admission of high-risk people living with diabetes diagnosed with COVID-19 and the application of a clinical practice guideline on clinical outcomes in a generalist and intermediate care facility. So it was a retrospective quasi-experimental study doing secondary analysis of an existing database. And the study design was used to assess a real-world intervention retrospectively between two predefined groups of people living with diabetes. So what we looked at was the experimental group. So those were the patients who were offered admission via the telemedicine team. And this was a direct admission from home to the Hospital of Hope. So that was versus a control group that went via the usual care. So they went from home to an EC, to an acute hospital, and then to the Hospital of Hope. So all 61 patients or people living with diabetes were accepted admission to the Hospital of Hope via the Vector community group, were included as the experimental group. And then 122 purposefully selected patients matching the inclusion criteria in a 2-to-1 ratio were identified. The two groups were matched for age, gender, and renal function. So we extracted data from the clinical database using a data extraction tool that was designed by the research team. And don't ask me too many questions about this. The statistical data were analyzed using Starter 14. Patient characteristics, comorbidities, and outcomes are compared between cases and match controls using chi-squared or Fisher's exact tests for categorical data and Wilcoxon rank sum, Mann-Whitney tests for continuous data. All statistical tests were two-sided with significant set at alpha of 0.05. Thank you, Katie, for that. So the study population was 183 patients in total. And I said we looked at all of the patients that were in the intervention group. And we compared it to a control group of 122 patients. So in our group, the intervention group, showed that 94% of patients were discharged compared to 89% of patients who were discharged in the control group. 4% of patients died, which equated to 2 patients in the intervention group, compared to 8% of patients in the control group. And then 2% of patients were escalated to a higher level of care, compared to 3% of patients in the control group.
Yeah. Everyone is diabetic, yes?
Everyone's diabetic, yeah. Yeah, so it's a diabetic goal with this one. There was no significant difference so in terms of our outcomes, there was no significant difference in any comorbidity between the two groups. So they were quite similar. And hypertension was the most common comorbidity in both groups. So the experimental group had better diabetes control than the control group. So those are the HbA1cs and admission. And admission random glucose was 10.2 in the in the experimental group versus 10.7 in the control group. But the discharge glucose levels, insulin requirements, and glucose-related adverse events were similar in both groups. In the experimental group, there was a shorter hospital stay. So 5 days in the experimental group versus 6 days in the control group with a p-value of 0.04. There was less occurrence of acute kidney injury with a p-value of 0.046 and less escalation of care with a p-value of 0.286, as well as less mortality with a p-value of 0.508. So before you ask me the question, I'm going to say, although not statistically significant, these results were actually clinically significant, especially at the time during a pandemic.
Yeah. Can I ask, did you adjust for the admission glucose control because it's coming in the experimental group? Better control. Did you adjust for that in all these analyses?
So our statistician did that. So she was involved with doing that. Yeah. So the experimental group's antibiotic use was 9% versus 35% in the control group with a p-value of less than 0.001. Oral steroid use was 30% in the experimental group versus 55% in the control group with a p-value of 0.03. And oxygen usage was also lower. So 21% on nasal cannula in the experimental group versus 56% in the control group with a p-value of 0.01. And on non-rebreather masks, the experimental group, there were only 2% of patients on those masks versus 12% in the control group. So generally, the oxygen usage was also lower. So there were lots of limitations. I'm just going to describe 3 for you. It was a small sample size. We had missing clinical data because we were working from an existing database. And we were using a quasi-experimental design, which does not use random sampling in constructing experimental and control groups. So it has low internal validity, but was the best fit for this context. So we obtained ethics approval from the Human Research Ethics Committee at the University of Cape Town. There was no risk to patients, and in terms of the benefits, this will add to the limited pool of data on inpatient diabetes treatment available in the South African context. So just in terms of discussion, so high-risk people living with diabetes in the experimental group are managed with good outcomes at the field hospital and were definitely not inferior compared to the control group. This is an idea is that there was significant financial and psychosocial savings, so with the extra cost and anxiety associated with no acute hospital admissions. And we showed that there was a less complicated stay with fewer patients requiring escalation of care or oxygen. So this is just a thought about cost. So total cost to company of the vector intervention was approximately 728,000 prior to the second wave, averaging out 19 Rand per call for the first 3,842 patients, each receiving an average of 10 calls. So cost per admission per patient of 75,127 Rand per patient was estimated for inpatient management of severe and critical COVID-19 patients in a general ward. So a study conducted in South Africa in 2007 estimated that the unit cost per acute inpatient days were between $38 to 103. And in 2007, that would have been 270 Rand to 737 Rand. And if we took that inflation into account, in 2021, it would be 572 Rand to 1,562 Rand per patient daily. So in the experimental group, the cost of emergency admissions, acute hospital stays, increased oxygen and medication consumption would have been significantly lower if costing measures had been applied to it. So the implied cost savings for eliminating the acute hospital stays in the experimental group in our study would warrant further investigation and would be immensely important in the current resource-constrained environment. And because October is Mental Health Awareness Month, we have to include something about mental health as well. So in China, a study including 1,733 patients who were discharged from hospital after having been diagnosed with COVID-19 found that 23% of patients reported symptoms of anxiety or depression. So another study in China reported that patients viewed their first 3 days in a COVID-19 ward negatively, and 38% of patients screened positive for either anxiety or depression or both. And a further study in China also reported there was post-traumatic stress symptoms in 96.2% of patients. So given the reporting of the burden of emotional turmoil in COVID-19 patients, one could assume that simplifying the pathway of admission for patients, as in this study, could reduce distress, anxiety, and post-traumatic stress in high-risk people living with diabetes electively admitted with COVID-19. So the study has implications for other COVID-19 field hospitals and possibly district-level hospitals in South Africa, and could inform strategy to prevent deaths in this high-risk cohort. Proving the successful application of guidance from tertiary hospitals in field hospitals with mentorship from specialists at tertiary centers could help to overcome the lack of access to specialist care in many parts of South Africa. So some of our recommendations were that we definitely need larger randomized controlled trials are required to compare the outcomes of glycemic management at the field hospital of people living with diabetes with similar COVID-19 disease severity. And further studies should look at how technology can assist in the coordination of care across all levels of the health system. The role of clinical risk factors as criteria for elective escalation of healthcare should be considered instead of waiting for severe disease to develop. And we should definitely explore more ways to enhance interdisciplinary, interfacility, and vertical collaborations. So it's a reference list, and those are details if you need to contact us. And so this is an image of a rainbow. And so the rainbow is a symbol of hope, and it was the symbol for the Hospital of Hope. So I hope that that's a positive way to end the talk. Thank you very much for your time.
There's 2 questions on the chat. Virginia, one is, do you have the data on the proportion of those offered admission who were actually admitted?
Yeah, so we couldn't get that from the Vector team. That was something that the Vector team weren't able to give us at the time. So that would be useful information, yeah, to know what happened to those patients, basically, yeah.
And the second question is, who did the randomization of patients to the 2 arms?
Yeah, it wasn't randomized. So that's the one thing. Yeah, so that was me. I was involved in the study. So yeah, so it definitely wasn't a randomized study. So yeah, we did a quasi-experimental study design. That was the only way we could do it. Because when we were involved in that process, we weren't even thinking about research. You know, it just sort of came afterwards. We were really thinking about saving lives at that stage. So this is just to have some way to capture that data. Yeah.
Yeah, I was wondering like how the experimental group had the better glycemic control. Like, that was just
well, it was slightly better.
It was like,
yeah,
it was like a couple of percentage
points. Yeah, basically, yeah. But I think we also had a very limited number of patients. So if we had a larger number of patients, it might have shown something different as well. As something to consider.
So all the patients that were admitted to hospital, how many had diabetes out of the total?
61.
Out of the whole period? For the whole COVID period? Because it really wasn't diabetic patients that went to hospital.
No. So that was an interesting thing also, because remember, we initiated that process towards later, mid pandemic, towards the end, basically. So that's when we initiated the process.
It was June, July.
Yeah, so it was sort of the middle of the
So
pandemic, basically.
The beginning of June.
Yeah.
And it was decommissioned but August or not?
Just before August, I think. Yeah.
So all the admissions that went through there, how many were diabetic?
Sure, I don't have the exact numbers. We do have another study.
That had a description of the whole inpatient cohort. Which I can quickly see if I can find that one. I think it was the one that Bonnie was the first author of. Yeah.
Because I mean, they were targeted, obviously, so they were significant.
Yeah, but they weren't targeted based on our data. They were targeted based on data that Prof. Davies had found before the Hospital of Hope even opened.
Right.
Tatum.
It's an incredible opportunity. Well done.
There were about 850 diabetic patients.
Missing data.
Yeah.
This must please be included when you do your follow-up.
Okay.
Is how many of these patients, of these diabetes patients, were overweight, obese, and smokers?
Yeah. So that's a very good point. Yeah, we do have some of that data, but there is lots of data missing because we didn't have a scale, unfortunately. So it was sort of a rough estimate for the BMI. But definitely, that's a very important point to follow up on in the future. Yeah.
And could you go back to your slide on recommendations? Yeah, because I think we need to look at what are the implications for what we've learned during the pandemic for routine care. How do we risk stratify diabetic patients for earlier intervention before they end up with their gangrene, with their whatever, for kidneys or eyes or whatever it is. How do we take the outcome of the study into routine practice?
Yeah, it's a very good question. I think it's.
In other words, what's the routine equivalent for the now world, the post-COVID world equivalent of the vector team? I suppose is another way of asking that question. What does the vector team become in our post-COVID situation?
It's a very good question. I think if we could definitely consider having a team like that, just managing our normal diabetic patients in our clinics. Just having a lot of the patients just anecdotally said, that just having somebody phone them and just ask them, how things were going made such a big difference, and also improve the relationship with the health system in general. So, I mean, having a team like that, I think would be very, very useful. But then also at our clinics or at our day hospitals, to make sure we're doing routine checkups, because if we did routine HbA1c, routine creatinine, then we could quickly get that data, and establish who we need to, focus on, basically, which I think would be available. But I think we sort of would need a lot of systems in place and a lot of technology in place for that, which we've, in a way, shown that it can be done. But it just depends on what type of level we're looking at. Yeah. Because, I mean, it would be nice. I think also just having more access to glucometers for patients also, even that, I think, is a small thing. But, if a patient actually has a glucometer, they can test the sugar. Somebody's phoning them, what's your sugar? And then can get advice and then decide, where you need to go from there. I think that would be so useful. Because a lot of patients don't have glucometers. Yeah. I think that was quite a loaded question. I'm not sure I'm the person to answer that question.
It's not just for you.
Yeah.
just the next step from the study. So how do we use the extraordinary experience of the pandemic in a constructive way?
Yeah.
Interesting. Tasneem also answered in the chat. I mean, the first question, there were 850 diabetic patients in total, and I've shared a link to the South African Medical. I don't know if you probably will have access to the meeting chat afterwards. And then Tasneem also responded to Steve's question about the need to foreground risk as opposed to waiting for clinical disease, which I think also speaks about the prevention promotive perspective about. And then the Provincial Health Data Center is a central resource. Because increasingly we have access to data and team data, so identify patients at risk. I mean, my understanding of the vector process is that it has also, in a way, been incorporated in the provincial data. There's a call center that Ronit wasn't involved with, that also looks at more general telemedicine support, or just having a call center for patients to phone to, especially if they're at home and they're not sure what to do with it. So I think that's probably more of a passive approach than to having an active risk-based approach. And like it's also said about knowing the precursors to pre-diabetic curses. Because I remember the one physician also said that, I mean, it was during the first wave, how COVID seemed to find the patients that are pre-diabetic. And obviously, with at the time, we didn't really understand the pathophysiology, all the receptors in the pancreas and the iron cells that are being involved, and how the process itself, the pathology, also could be diabetic in a way, but it also unmasked. Because I think it's the first and also the later waves, there were quite a lot of young people that were newly diagnosed that have the phenotype of type 2 diabetes, although they presented often with like type 1s or DKAs, which was so the disease pathology, the way it manifested clinically was quite distressing in a way, because it didn't quite fit what we know, what we thought we knew at the time. So maybe it also challenged our understanding of diabetes and what happens at a maybe more microscopic level. I was also amazed at your results that showed about the risks for inpatient type glucose control, because I think the one thing I recall also with the junior nursing staff and the monitoring of patients, now that we have these patients that we willfully submitted to an inpatient intervention with very tight control about the adverse incidents of neuroglycopenic events or hypos. And it wasn't, because I think there was the one concern, but do you now bring patients in from their homes that are at risk for high or complicated disease from COVID, and now expose them to very tight glucose control, and maybe in a setup that the observations and the staffing didn't really allow for? And I think that was one of the concerns at the time. But I think your results have also shown that concern maybe was unfounded.
They did do well. We had a lot of concerns at the time before we did it, but they did well actually, most of them. So.
From a change management process, any thoughts on the change management process, about how you think that was obviously about the way it was implemented and how the staff were brought on board?
So I think that's also one thing that also was to our benefit, is because we knew we had these patients coming in that were diabetic, they were high risk. We brought in a lot of people to help us. So we brought in somebody to train our nurses, so a diabetic sister, basically, which we didn't have initially. She came from outside to help train our nurses. We focused a lot, in our ward rounds to teach the medical officers how to manage diabetes, and we went through these guidelines very, very thoroughly with everybody. So that most of those medical officers were actually very astute in managing diabetes by the end of that. So that was really, really a good outcome. So training was a big part of getting it right, basically. And I mean, that knowledge is not only going to be with them, was not only beneficial for that period, it's going to be beneficial for the rest of their lives, basically. Yeah.
There's another question from Virginia. The construction of the control group, were these people who were not contacted by Vector?
Yeah.
Were these people who were not contacted by Vector and were matched with the Vector?
That's right. So those were patients that came via the usual system of care. So they would have gotten sick at home, then maybe presented to an EC in whatever state, then went to an acute hospital, and then were then sent to the Hospital of Hope. So those were sort of the normal patients, basically, normal process. So yeah, so that's the control group.
In the context of bed pressures, surgical disciplines often face a similar trade-off between admitting acute patients versus cancer-elected patients, which could deteriorate and become an acute and more costly admission.
Yeah. So yeah, exactly that, basically. Because I mean, a cholecystite, somebody with gallstones might benefit from a sooner admission and then removal of the gallstones versus waiting for a cholecystitis to develop, you know, which becomes more costly and more time-consuming and needs more resources. Yeah.
It strikes me that the pandemic accelerated a whole lot of processes that are much slower without the pandemic. So you know that a person who's running an HbA1c of 12 or above, it's just a matter of time before they end up with some disaster. In COVID, it was a matter of days or weeks.
Yeah. Days,
in post-COVID, it's a matter of months or maybe even years.
Yeah.
So it's kind of highlighted that the role of, because that vector thing was a central thing in supplementing our local health services. So someone was coming in over the telephone saying, hey, you know, we've noticed you've got a positive test, we know you're diabetic, do you want to come to hospital?
Yeah.
Like, whoa, you know, it's not their local practitioner, it's not their local clinic, it's another sort of proactive. I mean, imagine if that had continued in some form now, that we were contacting everybody with the HbA1c of running over 12.
Sure.
Because we know it's going to happen, sooner or later.
Yeah.
And that there was this additional, I don't know, alert system.
Yeah. But not only would that improve costs, because in terms of patient outcomes and, you know, like there'd be less amputations, less, you know, all of these other things that we have to deal with when our diabetics are poorly controlled and ill. So, I mean, that could change things quite for us, yeah.
Excellent.
Was there also from Virginia and Taslim also about just Taslim confirmed selection criteria for the matching, and Virginia also mentions that the telemedicine is also being used in Metro for diabetic patients in Hanover Park, and then also loss to follow up patients for TB. So much effort taking place, and this is something we need to have on our radar for teaching of registrars and undergrads. So I think the whole innovations flowing from the telemedicine vector initiative, it's taken forward as well.
I think it's also just on the issue, and this is kind of watch this space, but also reaching out to people that might be interested. The BME, they are developing virtual kind of test beds. So there's opportunities for registrars to do IMEDs, potentially in developing these test beds and testing these virtual test beds. So there's opportunities for kind of improving access to care especially where access is challenging, like rural settings, more undeveloped settings, and how we can link up people from communities with expertise as such. Yeah. I was, by the way, I was one of the English on the
Joe's repeat.
Yes.
Yeah. Okay. Thank you very much.
And thanks to all the colleagues online for joining us.